For those who haven't met before, I'm the interim regional education coordinator with SWASN, which is based at a London Health Sciences Center. So I'll be hosting stroke rounds today. I've got some introductory words to say, and then we'll get on with the presentation here shortly. Today's presentation is titled Enhanced Community Discharge Destinations, and it's presented by Margot Culver, who is the Community and Long-Term Care Coordinator for the Southwestern Ontario Stroke Network. Jeanette Moss, Community Services Support Supervisor with OneCare, and Laura Veenstra, who's a Therapeutic Recreation Specialist. This group would also like to thank Karen Hayes and Megan McPherson in the creation of this presentation. So you likely received handout slides for today's presentation. Those are available in the reminder email that went out yesterday. This presentation will be recorded and archived, excuse me, and can be accessed through the link that will be provided on the follow-up email that you'll all receive. We've enabled the mute function for this meeting, so those of you who are joining are muted on entry and won't be able to unmute yourself. So what we're going to ask in terms of questions is if you do have a question, please just pop it in the chat box, and I'll make sure that I read those out when we have our Q&A period at the end of the presentation. Please remember that views expressed today are those of the presenters and not the platform being used. As I already mentioned, we will be having an interactive component during the last 10 to 15 minutes, and this panel is keen to take any questions you may have about the program they're discussing today. Please do put those questions in the chat box for everybody to see, or you can send them to me privately if you wish. Please complete the evaluation. I've linked the SurveyMonkey evaluation link in the actual chat box itself. So for those of you who wanted to click on the link that's in the presentation you're seeing, if you just look in the chat box, you can actually click a linkable link right there for you. To do the evaluation, you can complete it online, or you can fill out the paper copy that was attached to the email invite and send it in to us. Certificate of attendance were also attached to the email invite, so please fill in your name to the certificate and keep that for future reference. And we'll get going through these slides now. So this Provincial Stroke Grounds Committee has mitigated bias by ensuring there was no industry involvement in planning or education content that you'll see today. Here's the title of the presentation, as I mentioned, and the 3 presenters listed at the bottom there. This group has no relevant disclosures. And the objectives today are listed on the screen. So this group will describe the creation and uniqueness of the Life After Stroke program, discuss benefits and processes involved in these programs. They will then explain the program evaluation methods and challenges. And lastly, they're going to describe the impact on program participants. I'm going to hand it over to Margot Culver.
Thanks, Morgan. Before I get started, I just wanted to provide a little bit of context about the presentation. So the programs and the processes we're going to be speaking to today are pre-COVID. So as you will know, many community programs had to close or, start providing virtual services, and some of them are still having capacity limitations. So what we're discussing today is what the program looked like pre-pandemic, just as an FYI. So I think most of us will agree that the critical window for stroke recovery is within that first 3 to 6 months post-stroke. But it doesn't mean that after this period of time that recovery is over. And in fact, we're learning more and more that recovery can continue for many months and in fact, many years post-stroke. Next slide. So we're very fortunate here in the Southwest to have various outpatient and community stroke rehabilitation teams that can provide therapy during that first early days post-stroke after an inpatient stay or an acute stay. In particular, in the Southwest LHIN, we have community stroke rehabilitation teams, and they're based out of Parkwood with sites in London, Seaforth, and Owen Sound. and they offer specialized stroke rehab services to stroke survivors so they can practice in a real life setting, so within their own home. Unfortunately, even though we are so lucky to have these teams, their services typically only last about 8 to 10 weeks. And so we're still missing that key component during that period of enhanced neuroplasticity. Next slide. So it was these community stroke rehabilitation team members who really identified this lack of available discharge options for their clients' continued recovery. It was very unsettling to them to be discharging clients who were very motivated and were working really hard towards their goals. And so discharge became a bit of a stressful period of time for both the clients and the team members. So even though there's other programs, and of course there are always other programs that exist, things like group exercise programs and things, but there remained challenges in that sometimes the equipment wasn't appropriate, or there was challenges to accessing transportation and things like that. Next slide. So when we were looking at our communities and what was available, we started looking at the adult day programs, knowing that they're designed to keep people living in their own homes and communities, and to keep people living in their own communities. And they also provide cognitive stimulation as well as physical exercise, social stimulation, health monitoring, and caregiver respite. But the nice thing about these ADP environments, adult day program environments, is they also included the availability of transportation, and their staff were already familiar with stroke clients. So when we started thinking about how to fill the recovery void in the community, adult day programs seemed like a logical fit. So what we started to do is pull data. So we had the community stroke teams identify communities within the region with the largest number of stroke survivors. And then what we did was we approached community support agencies within those areas to gauge their interest. And once we had established those partnerships, a business case was written and submitted to the Southwest LHIN, and we were successful in receiving funding. Next slide. Eventually, a total of 7 stroke-specific adult day programs were implemented across the Southwest. Originally, the referrals had to come through the community care, what was then the Community Care Access Center, what is now LHIN Home and Community Care. However, the Stroke Network was able to negotiate with the LHIN to have them remove their care coordinator from the middle of the referral process, which meant that the CSRT teams or the outreach team members could now refer directly to the stroke-specific adult day programs. So we're a little bit different, and in order to differentiate ourselves from those regular programs, we needed a new name. And so what we did was we polled all of the clients in our programs, and they chose the name, and the name they selected was Life After Stroke. So what is Life After Stroke really? How are we different? These programs are really focused on recovery and on individual client goals. The other unique thing is that they received funding, and in this case through the Southwestern Ontario Stroke Network, to purchase specialized equipment. They also have staff that are specially trained in stroke best practice care, and those same staff receive ongoing education and support from our community stroke teams who specialize in stroke care. We're also different from regular adult day programs in that we're transitional in nature or time limited in nature. And again, it's based on client goals. The nice thing though is that we don't just discharge people, but when it is time for discharge, we support them to find other options in their community to maintain their recovery. Next slide. So there are many benefits to the Life After Stroke program. They provide a discharge destination for those community stroke teams or those more formal rehab programs. The peer support really allows clients to share experiences and engage with other people who have similar challenges and deficits. We also know it can help reduce social isolation and associated depression. It provides that opportunity for caregiver respite and education. But what we've also learned is it can also help avoid premature placement in long-term care. And we'll touch on that a little bit later in the presentation. Laura?
Thanks, Margot. So who are the Life After Stroke participants? As mentioned, these programs were created as a discharge destination for those who completed outpatient or community-based stroke rehab. So as a member of the interdisciplinary rehab team, when we're considering who to refer to a Life After Stroke program, we're looking at how that individual would benefit from the additional supports, including supervised exercise programs or the peer support that's available in the program, as well as just participation in other activities like thinking and memory activities. We're also assessing a participant's ability and activity tolerance to ensure they can safely and actively participate in a full day. So many of the Life After Stroke programs run from about 9:30 to 10 to about 3:30. So it's a full day of lots of activity. And we just want to ensure that person attending is set up for success. But with that being said, I think the programs do a great job at providing opportunity for rest as well, because we know that's so important in recovery. A lot of the programs have relaxation areas, some lazy boys or quiet rooms. So they do meet the needs of those attending. And another thing we assess is also their motivation to continue to work on their stroke recovery goals. So the interdisciplinary team usually will get together when we're thinking of who would be appropriate for a Life After Stroke program and talk about, were they motivated in rehab? Were they an active participant? Do they have goals they're still working on? And have they demonstrated self-management? Because we're really looking for participants who understand that's a transitional program and it's a goal-oriented and directed program and have just goals and active goals that they're working on. Next slide. So why were Life After Stroke programs created in partnership with the community stroke rehab teams? I think the Canadian best practice recommendations really answer that question because they recommend that people with stroke are provided with information or referrals to a community-based resource for engagement and activities. So as a therapeutic rec on the community stroke rehab team, my role is to support clients to get back into the activities they enjoy and meaningful activities, but also help to integrate back into a community setting. However, sometimes those programs they enjoyed before their stroke or the community programs that they might have an interest in the future just don't meet their needs or not suitable for their functional ability at this point in their recovery. They also, sometimes the community settings might not be accessible. There might be transportation barriers. We often find too that the person who's had a stroke still wants to improve on their confidence or some skill sets before returning to a community setting. So the partnership really creates an opportunity for stroke survivors to engage in a community program that's meeting them where they're at in their stroke recovery journey. And as a member of a team that's referring clients to this program, it gives us a lot of confidence in knowing that the Life After Stroke program is available and that the participants and the staff of the program will continue to receive stroke specialized consultation, support, and training as needed from the community stroke rehab team. So another important reason why the partnership between CSRT and Life After Stroke programs is the warm referral. So often when someone's navigating their stroke journey, they're very overwhelmed. There's lots of information coming their way, lots of different people, whether rehab teams or home and community care supports. And we find our partnership really just takes something off their plate. So if they're interested in a Life After Stroke program, they don't have to navigate that journey. We're going to do that with them. So we'll set up the tours and the trials, we'll complete the referrals, and we share all their stroke rehab information with their consent to the Life After Stroke staff. So this really ensures that continuity of care. And lastly, a really big important part of our partnership and the program's design is reducing vascular chronic disease through exercise and providing secondary stroke prevention education. So with this partnership, the Community Stroke Rehab Team, which has the specialized stroke clinicians, can support the Life After Stroke staff with ongoing best practice techniques and interventions, provide them with various resources, whether it's like online resources, written material, aphasia-friendly material, and the topics, that we're sometimes giving them information on so that we know the clients attending continue receiving secondary stroke prevention, include health and wellness resources, different education, exercise programs, training on specialized equipment, and all of that, helps reduce the risk of a secondary stroke. Next slide. So how does this partnership work? When the interdisciplinary stroke team determines a client is interested and would benefit from the Life After Stroke program, the outpatient or community team will set up a tour or trial of the program. Often that means we're going to accompany that person to the tour or trial. So setting up transportation, trialing accessible transportation with them, meeting them there, helping them navigate a new community setting. And then when they're in that trial or tour in the program area, they have an opportunity to meet the other participants, to meet the Life After Stroke staff, and also observe the program in action. And so it's really beneficial for that client to get a good feel, like, is this a good fit for me? And will this help me with my continued stroke rehab goals? But it also allows the staff to determine whether this client is a great fit and if they can manage that client's level of care in the program. When it's determined that it is a great fit, the community stroke rehab team or the outpatient team will complete a referral and send that with the discharge summary to the Life After Stroke program coordinator. So the referral is a summary by the interdisciplinary stroke rehab team, and it includes all the client's stroke recovery goals and interventions and recommendations. And so they can have a background on what that individual has been working on in regards to their stroke recovery. And then once they have that information, it's up to the stroke or the Life After Stroke coordinator to connect with them just to determine start time and complete any additional paperwork. So on the last slide, we talked about how the community stroke rehab team partners and supports the Life After Stroke programs through ongoing consultation. And to successfully manage that partnership and all the resource needs and interests, rehab assistants from the community stroke rehab teams are assigned as a contact for the Life After Stroke staff. So this is very unique to these programs. Rehab assistants on the community stroke team are the team members that are seeing the client usually the most. They're in their homes or they're working with them on their rehab 2 to 3 times a week, and they're bringing all their prescribed therapies from all the different clinicians together to practice different interventions and help them become comfortable in any recommendations for their ongoing recovery. So the rehab assistants are very knowledgeable in stroke best practice and are a great resource to the Life After Stroke programs, but they're also that one person they can connect to. So the Life After Stroke staff, if they have questions or concerns or want some information, they have one person to connect to, and that person can really direct them and guide them to who would be the best fit or what resources they can share. And the rehab assistant also is someone who will set up tours and trials and helps manage the wait list. And they're also that just familiar face at the program if they worked with them during rehab. So this slide is really just a summary of the community stroke team support to the Life After Stroke programs, and it's what differentiates us from a regular adult day program or other community settings. So we see in this first point that as a refresher, the community stroke rehab team staff provide a warm handoff and transition supports for participants. So they're getting a lot of information. The Life After Stroke staff will receive a lot of information on the health history and stroke recovery history of the participant. And then when they are transitioned into the Life After Stroke program, the staff members of the Life After Stroke program can review their goals, create new goals, and provide a care plan with them for their participation in the Life After Stroke program. As mentioned, before the community stroke team does support in stroke best practice, but sometimes there is the opportunity to provide one-to-one support to a participant and with the staff of the Life After Stroke to support the participant in their prescribed exercises. Just to note, this isn't always a possibility depending on staffing, but it is something that has worked out occasionally in the past where we do encourage the participants to bring their community stroke rehab therapy binders or their rehab binders. So basically that is all the information they gathered from their rehab time with an outpatient or community team. So it's recommendations, exercises, worksheets. We do encourage them to bring those to the program. So if there is that opportunity for some one-to-one support, helping with, for example, like a GRASP program, then they have that information with them. Also, if there's opportunity to maybe work on some speech and language worksheets, then they have that information there. And sometimes throughout the program, they have time just to do individual activity in their own time. And so this is a great resource too, to bring their book, binder of prescribed therapies with them to the program to continue working on those. We also, as the community stroke rehab team, provide demonstration and training of stroke best practice techniques to the Life After Stroke programs. So this could look like a physiotherapist going in to do some training and demonstration on the new step, or an occupational therapist going in to do training on a GRASP program or upper extremity exercises. And we also have the nursing or registered nurse with the stroke program who could go in and really do some education on blood pressure monitoring and recording and education around that. And so there's lots of different opportunities for the stroke team to continue to provide training to the Life After Stroke program. On the bottom there, we also can organize planned and scheduled group education sessions. So oftentimes the Life After Stroke programs will get people from the community to come in and provide group education sessions, and they also can pull from the community stroke team resources. So that might be an occupational therapist going in to talk about pacing and fatigue after stroke. We're doing a lunch and learn around strategies to help around adjustment after stroke. So there's lots of different opportunities for education sessions with the staff, but also with the clients and the participants. And then lastly, the community stroke rehab teams offer check-in visits to observe the program in action and provide support. So at the beginning, when these programs were first starting up, within probably about the first 6 months or so, there was a lot of check-ins from the team and from the rehab assistants, weekly check-ins, just if they had questions or to help get the programs running with some stroke best practice intervention. However, after around 6 months or so, when the programs are running smoothly and everyone's feeling comfortable with the Life After Stroke program, we really encourage the staff to connect to the rehab assistant assigned to them when they have questions or when they would like different support. The rehab assistant also is a regular face to the program, so there's always opportunity for check-ins and for that communication. And just for an example of what that can look like, so a client may be 6 months into participating in the Life After Stroke program. The staff is finding they're really improving in their walking, and they've been using a walker, and they're wondering, well, can they now use a quad cane? And so they can ask the rehab assistant to connect to the physiotherapist who worked with that client, and then that physiotherapist could go in and maybe reassess and graduate that person to a different walking program or exercise just to help further their recovery. Okay, so I've talked a lot about the community stroke rehab team supporting the Life After Stroke through information sharing and training. So this is a sample training schedule. It's what was used when the programs were first starting up. So there were a couple of sessions where the community stroke interdisciplinary team would train and provide education along these topics that you see on the screen to the staff of the Life After Stroke program. The CSRT interdisciplinary team, along with support from the Southwestern Ontario Stroke Network, assist in this training and ongoing training. So the idea is hopefully every year they can have refresher days. And then also the idea is to offer new training as it comes up. So if the staff feels like they want some more training around how to support their participants that have aphasia, then, at any time they can connect back to the stroke team, and the speech therapist or speech pathologist on our team can set up some training sessions too on specific topics. Next slide. Outcomes and evaluation. So as most programs, we want to evaluate that it's beneficial to the participants, but also we wanted to have some data behind these programs just to back that they're essential as part of the community-based stroke recovery program options. And so the outcomes that we're using to collect data for the Life After Stroke programs are the Functional Independence Measure, which is the FIM. And so the FIM assesses 6 areas of function, which fall under 2 domains, the motor function and cognitive function. And the score is based on how much assistance is required for the individual to carry out activities of daily living. So the higher the score, the more independent the person. We also use the outcome Return to Normal Living Index, or the RNLI. And that was developed as a short and simple way to assess an individual's reintegration into normal living. And so for that, also, the higher the score, the more reintegrated to normal living has occurred. So these outcomes are also used by the outpatient or community-based rehab teams, and they're completed at intake. So when that outpatient or community-based rehab starts. And then we also complete them again at discharge, which is usually 60 to 90 days after intake. And then again at a 6-month follow-up following discharge. So for the CSRT clients, or the participants of the Life After Stroke program, they ideally would have their 6-month follow-up evaluation completed when they're in the program. And so with this in mind, we keep track of the Life After Stroke participants' FIM and NRLI outcome scores as a way to evaluate and track their recovery. So the scores are captured when discharged from the outpatient or community rehab, and then again at a 6-month follow-up for the Life After Stroke participants. Next slide. This is just a visual. So this is capturing the average RNLI and FIM scores of all community stroke rehab team clients between January 2019 and March 2020. So on average, we can see there's an increase in both the FIM and RNLI scores at discharge, and then again at the 6-month follow-up. And I think this is important because it kind of tells us the 6-month follow-up that there is improvement in the client's functional independence in completing activities of daily living, and we see the client is more reintegrated to normal living activities 6 months after discharge. On the next slide, this is a visual of a sample of just the Life After Stroke participant scores. So this is also from January 2019 to March 2020, but of just those who are actively engaged or participating in a Life After Stroke program, and we see the same findings, that there is an improvement in their FIM scores and RNLI scores at that 6-month follow-up. However, I think it's important to note what these scores and numbers don't capture. So participation in the Life After Stroke, they're always working on their stroke recovery goals. And so, yes, we're doing outcomes and seeing where there's improvements, but we're also knowing that maybe on the FIM, they improved by 1 point, but that meant they returned to independently using the washroom, which is huge for someone's independence. Or maybe on the RNLI, they improved by 1 or 2 points, but in that time they got their license back and have returned to driving, which also improved, which is a huge improvement for their life and providing more independence. And so I think it's important to note, even though it looks like maybe just a slight improvement, what has been improving and the goals that they're achieving are really adding to their quality of life, and they're achieving those rehab goals that they've been working on through their stroke recovery.
Yeah, so hi, I'm Jeanette, the supervisor of the Clinton Life After Stroke program. And the Life After Stroke programs have their own evaluations that they complete with the clients. A quality of life measurement was created specifically for these programs, and it's completed on intake and on discharge. So some of the areas we measure are mobility, self-care, usual activities, their pain, discomfort, anxiety, depression, and it's rated on a scale of 1 to 5. And depending on the program, some other testings may also occur. So some of the specific testings, they're listed right here. So each program completes stroke client testing to determine progress towards individual goals. And the Life After Stroke coordinator works with the community stroke rehab team to determine appropriate testing tools and measures. So on admission, we do goal setting. We usually pick a couple of short term, and then we pick one a little bit longer term, just to, keep them on track, give them something to work towards. The fitness and cardio tracking, so that is the treadmill and the new Step T4 bikes. They're done every time they come to the program. We keep track of that for them. And blood pressure monitoring is done monthly or on an as needed basis. Sometimes we have doctors' requests, so we can do that weekly as well. Then the 6-minute walk test, the tug test, and the Berg balance test, they are done every 6 months, and then we keep that information together, and we will make graphs out of them to sort of see their progress. So one-time funding was received from the Southwestern Ontario Stroke Network, which allowed programs to purchase appropriate equipment. And the community stroke rehabilitation staff were available to train the Life After Stroke staff to use them in a safe and proper manner. So the new Step T4 bikes are very popular. We have 2 in the Clinton program, and the clients are basically lined up to use them, almost to the point where they sometimes fight over who gets to use them first. So they're very exciting for the clients. We have them go for 12 minutes, and we track it keeps track of how many steps they're using. It's in steps. And also there's a workload level from 1 to 10. So we keep track of their workload level as well as their steps that they complete in 12 minutes. And they have to hit a certain amount of steps, which is 1,000, to move up to the next workload level. We also use a treadmill. Not all clients can use the treadmill, but for the ones that are able to use it, it's very beneficial. Ours starts at an extremely slow speed because obviously that's a safety feature as well. We have a hand bike, upper extremity exercises, the grass kits. We use free weights and the TheraBands and exercise balls in our group settings that we do with them. We have practice stairs that we do in the program, but we also have real life size stairs down the hall. So it's sort of once they graduate from those practice stairs, we kind of move them up to using the real stairs. We have the other recreation supplies, basically like any kind of physical activity like rugby, bowling, golf. We even got axe throwing right now. It's all modified, it's all safe, and we use those for the clients, the social part of it and the physical part. We have our newest equipment, which is the activator poles, and they have been a great hit. I'll talk a little bit more of them on the next slide, but they've been a great success with our rehab part as well. So I'll talk about the activator poles on the next slide here. So activator poles are being used as a best practice for rehabilitation centers, clinics, and community programs across Canada, the UK, and Australia to improve outcomes in gait, balance, core strength, while inspiring the active living. They're evidence-based, and they're used in therapy to reduce the use of passive mobility devices such as canes, crutches, and walkers. So some of our clients that are using canes and walkers, we've tested it out with them, and at first, there's a little bit of buy-in. They thought, kind of, what are these poles for? But after we got explaining them and using them, it's really made a difference in their walking patterns and keeping them in that upright posture. So they've been instrumental in promoting the upright posture and a functional walking pattern compared to the canes and walkers, which definitely helps with their with the client progress in their goals. So in the picture on the left, I'm teaching a group, and the poles help to enhance the exercise program to improve upper and lower movement and flow and promote proper posture. So we're all just sitting in chairs in a group circle here. So there's a ton of seated exercises you can do. So if somebody is wheelchair bound, they can still participate in the group exercises in the seating position. And on the right, I'm instructing a one-on-one walking program. So we do this one-on-one, and it focuses on the core strength, gait, stride, and arm swing. And one of the biggest things with the walking program with the activator poles is the upright posture, along with preventing the hip hiking. We really noticed a decrease in the hip hiking with these poles because it's forcing your whole body to work together. So that's amazing. Also, the arm swing, a lot of times the affected side isn't being involved, especially if they're using a cane. So it's really helping with the arm swing. Now, if they're only able to use one pole, there is a way that you can still use these for walking device with just the one pole to replace a cane as well. So there's lots of different techniques that you can use with this. So I have received my master training for urban pulling and the activator course, and I've taught the here in Perth. I've got the here in Perth Community Stroke Rehab team certified in the activator poles, and they've been having great success with their clients. So there's a group there that the clients are they're really seeing the benefits using these poles with their clients. So the One Care Life After Stroke program is in Clinton, and we've been running the stroke program for about over 20 years. But in 2008, that is when we partnered with the Here in Perth Community Stroke Rehab team, and that took it to a whole new level. So having access to the stroke team gave us the additional knowledge and expertise that was needed to introduce new program and to revamp our rehab program, or to introduce new equipment, I should say, and to revamp our rehab program. The continued support from the team and ongoing access to them has contributed to the great success of our program. We always like to thank them because it's a wonderful partnership, and I know all the other programs really appreciate having that partnership with them. So in Clinton, our program runs from 10 to 3. In the mornings, we focus mostly on their rehab, their exercise regimen. We make an individual exercise regimen for each client, and we tick off everything they do, and we keep track of all their exercises because it's really important to show that progress. And in the afternoons, we focus more on the cognitive and social and the educational component of the program, which includes health updates and secondary stroke prevention education. So we're going to show a short video right here now, just to give you a little bit better understanding of how the program runs. And the other Life After Stroke programs have modeled theirs off of the Clinton one, but still each program is unique in its own. So not all the stroke programs have the swim program. I know we're one of the lucky ones that have access to a pool fairly close by, but I know some of them do. So that is sort of an optional part of the program. And not all the clients have to participate in it either. It's sort of their comfort level and ability. You may have noticed the video. I love watching this video. I've seen it many times and it still brings a smile to my face every time. You may have noticed some outdated items in there, like the big tube TV and perhaps some of the fashion there, but we like it because we never age in the video. So that's awesome. So the next slide is talking about discharge. This is absolutely the hardest part of our job, I think. So when clients are coming into the program on intake, we do tell them that it is limited in nature, the program. So how do we go about it? I know that's the biggest question. Well, how long is it? Is it 3 months? Is it 12 months? Is it 6 months? So we go by the testing results, and they're used to help determine if the goals are met or if we need to alter the goals, and it helps us to plan for discharge. If we do have to discharge a client, or I shouldn't say if, when we do, because we do have to, we offer the client a blended ADP day. Some of them will transition into it, but it's not always successful because it's a different program in nature and it's not maybe exactly where they're at, because a lot of times the stroke survivors are a bit younger and it's not a perfect fit. But some of them are. Sometimes if their health declines or their cognitive level declines, it does become a bit more of a blended fit for them. And occasionally we'll get some clients that discharge themselves if they feel that they've made enough gains and they can function on their own and remain at home. We have had some, it's not a common thing, but there are some, and that's success for us as well. So, and if there is no wait list, I'm not sure of everybody's wait list. If there is no wait list, then there's not an urgency to have to discharge. But as soon as the wait list starts building up again, then you have to obviously make those transitions happen to bring in the new client. So the next slide here is, I was asked to talk about one of our success stories, and it's really hard to pick just one because we've had quite a few that we're quite proud of. But this one really stands out because it really serves the purpose of the program. So we had a client come to us at 38 years old. So he was discharged from the community stroke rehab team in March, and he was put on our wait list from March until June. So during this time, his gains from the rehab program with the community stroke rehab team had declined considerably in that 3-month period. In June, he started attending the Life After Stroke program, and we worked on building his strength again. Later in that year, unfortunately, things had changed in his life. He had minimal, limited supports, and he was looking at long-term care as his only option. And again, this gentleman is 38 years old. You know, not a great fit for long-term care, but there was no other options for him at this time. But if he did attend long-term care, that would mean a discharge from the Life After Stroke program. And he did not want that because that was sort of his saving grace to keep him, you know, as independent as possible. So we came up with a plan for him that he would attend twice a day. So the Clinton program runs on Tuesday and Thursday. So we got him in on both the days and continued to increase the strength and work on his ADLs. So he went from being wheelchair bound to walking with a quad cane, and he eventually was able to walk 220 feet. So that's a pretty big accomplishment for him from coming in wheelchair bound. We noticed a huge gain while he was attending twice a week as opposed to just once a week. And he was able to rethink his plans and move to a retirement home instead of long-term care home, which allowed him to continue with his rehab journey in the Life After Stroke program. He was very dedicated and committed to the program. So, I mean, happy ending for him. So not only did he maintain his gains, he also continued to improve. And now at this point, we're now talking a 1.5 years post-stroke, and he was still making gains in the program. The success of this program enabled him to buy his own house and live on his own. So that was like huge for him. He's so proud of his accomplishments, and we are still so proud of him. And to this day, he still remains at home and he's managing fine living on his own. So that is I would have to say that's probably our biggest success story, from keeping someone out of long-term care. We were happy with the retirement home option, but I mean, living on his own, buying his own home, he's a proud homeowner again, just sort of put the icing on the.
So I also just want to close by sharing a success story, and this is a post-pandemic success story. So a lot of what we've talked about in this presentation is about the partnership between the Life After Stroke programs and the outpatient or community rehab teams pre-pandemic. But I really want to commend the programs for doing what they can and offering this program despite the ever-changing precautions and adaptations they had to make due to the pandemic. So many of the Life After Stroke programs were running throughout this past year and a half, whether it was just smaller, they all had smaller numbers, but some were creative and would offer 2 groups a day, morning and then another one in the afternoon, or alternated every other week, so that these participants still could engage and participate in their Life After Stroke programs. And just this last month, we received a success story, and we wanted just to share this. Jerry did consent to sharing this with this presentation today. So as you can see, in July last year, Jerry had a stroke and he was admitted to the stroke neuro inpatient unit at Parkwood Institute. While he was there, he often talked about goals of returning home to live independently and returning to the driving process, as well as returning to work. So after his inpatient stay, he was discharged to the community stroke rehab team in September. And the team members worked very closely with him on those goals. And by the end of our involvement, he was living independently and safely in his home. We discharged in December of 2020, and he was informed about the Life After Stroke programs. He wasn't sold on it right away, but after a month or so of not having that service, he reached out to the team and wanted a referral to the Life After Stroke program. So in February of 2021, he joined the Strathroy Life After Stroke program 1 day a week. And during this time, so from February up till this past month, he passed his driver's test, which he returned to driving. That improved his confidence and independence. And recently, the program let us know that he was discharged, but it was a happy ending because he is returning to work part-time at Western University and is still working towards a full-time return to work.
All right, thank you. So just to wrap things up, I wanted to end by noting that the Canadian Stroke Best Practice recommendations indicate that higher levels of support in the community post-stroke have been associated with greater functional gains, less depression, and improved mood and social interactions. We really feel that the Life After Stroke programs are the perfect way to ensure stroke survivors have access to best practice stroke recovery services during that critical 3 to 6 month period and beyond. Partnering with existing day programs makes it a no-brainer. These programs are already in existence and they're easy to replicate. So we would just say, if anyone wants further information, has questions, or wants information or help with a business case, the following slide has our contact information. And I just wanted to give a shout out to all of our partners that you can see there on the left that have some of our Life After Stroke programs here in the Southwest. And if you get a chance, we were hoping if we had time today, we would be able to show the community stroke rehab team video that's on this bottom YouTube link. But it's a newer video that really kind of describes the partnership. So if you were trying to sell it in your region, it might be a nice, video to share with your stroke partners or potential partners. And I'll just pass it back over to Morgan.
Lovely. Okay, great. So that wraps up the presentation portion of today. Just taking a look in the chat box for some questions. Before folks pop off, I just want to make mention, please do take a second to fill out the the evaluation, which is linked in the chat box. And also next month's provincial stroke rounds are going to be held on November 3rd with the topic of advanced care planning for stroke with Dr. Ng, Jillian McGuire, a nurse practitioner, and Lee Barr, speech language pathologist, all from Hamilton Health Sciences. So with all that being said, now let's get into some questions here. I know Rachel Dunn had a few in the chat box. So this one may have been addressed, but maybe we can talk about it again. What is the maximum amount of time one can be in the ADP, and who provides the secondary prevention education? Is it staff at ADP?
Well, the time one I'll answer. The time one is really dependent on client goals. I think Jeanette can probably, and Laura can speak to what the average looks like. But again, we're looking, 3-6 months. Some people have stayed as long as a year. And again, some people choose to stay even when their goals are met. If there's not a wait list, we don't send anyone packing. But ladies, correct me if I'm wrong.
No, you're absolutely right, Margot. When we do the intake with them on admission, we kind of say 6 months is sort of an average time frame, but it can be more or less depending on the individual and the wait list. So we do give them that heads up. Probably realistically, they're all at least 6 months, if not a bit more, in with my program, anyways.
And Laura, I'm thinking you answered the secondary stroke prevention one. So Rachel, I'm not sure if you caught it, but Laura mentioned that the community stroke team gives resources and education to the ADP staff so they can provide that, but they're also able to come in and provide group education sessions as regular ongoing groups that the Life After Stroke programs have. And sometimes it's a social worker or a nurse or what have you, depending on what the topic is. But it's a nice place to be able to continue that secondary stroke prevention education.
And I do think the Life After Stroke staff do an amazing job and are very resourceful at presenting secondary stroke prevention as well. There's so many online resources that they can pull from, and different, like just showing videos and just having that interaction about online resources is very popular in the programming.
Great, thank you guys. Hopefully, Rachel, that you got what you needed out of those answers. A few more questions in the chat box. Will slides be made available to us? I will for sure send the slides out again with the follow-up email, but if you haven't received the slides yet, please just make sure you leave me your email before you pop off the WebEx today, because odds are you're not on the lists we use to share the slides.
Morgan, there's a question about the FIM score.
Yeah. For FIM scores, do you have a range as to what might be equivalent to mild, moderate, or severe stroke functional deficits? And that's from Rob.
Laura, you're muted.
So I don't know how to quite answer that, but I do know, so the scores that we're seeing, yeah, I don't have it all in front of me, but we rate basically, if you're familiar with the FIM, it's 7. So we're scoring high if you're independent and safe in any activity of daily living, or the functional motor skills or cognitive skills. And then if you need total assistance, that's a 1 on the scale. And so we're just looking at higher the number, the more independent. And but I feel like I'm not the one that can speak too much into the FIM. I apologize.
Margot, you're on mute.
Deb, our rehab coordinator, is saying that the FIM scores in the graph would be in the mild category. Thanks, Deb.
Okay, let me just take a look here through the perfect. Okay, lots of positive feedback in the chat box. We've got one more question that just popped in from Rachel. Are the ADPs covered by OHIP?
No, the ADPs, all adult day programs, or most of them, I should say, not all of them, are funded by the LHINs. And then, so and all of them have a little bit of a different cost. So in our Southwest LHIN, during Access to Care, day programs were set at a $10 fee, with the exception of some of the ABI programs who are funded a little bit differently. And then the clients just have to pay extra if they want things like transportation or bathing or that type of thing. There are some in other areas and LHINs that have private programs where you would probably pay a bit more. But again, in every different region, depending on how the local health integration networks fund them, the prices will be a little bit different.
All right. Are there any questions remaining in the group here? Oh, let's see what we got here. Since LAS does not require a LHIN referral, we are finding the transition of discharge to ADP broken. That's from somebody named Gibson.
Okay, I maybe don't understand the question. So we actually wanted the LHIN removed from the middle because we felt like our community stroke team members were already professionals and they knew their stroke clients better. And so sending that referral to the LHIN or the CCAC or whoever it may be was adding an extra step, and it was really slowing things down. Kind of putting someone in the middle of things. And so this way we're able to expedite things. People can go to the stroke teams and then whoosh right over to the adult day program. So if you, yeah, some areas are, again, every LHIN is different, and every adult day program in different areas are different. They may not have to have their referrals go through the LHIN, but we did, and we were lucky we were able to get rid of that. So broken
Margot,
has need of
I think
augmentation.
they're also wondering how to discharge them from the Life After Stroke program to the blended ADP.
Since LAS did.
That's how I'm reading the question.
Okay.
The transition of discharge from the Life After Stroke to the blended ADP program. So for us, we would have to get the LHIN involved to do the referral to the ADP. They would have to get re-involved or start with the involvement to the blended ADP program.
Thanks, Jeanette.
Okay, I hope that answers the question or the comment regarding the challenges with the LHIN referral and the transitions there. It's coming up to 9 a.m., so I'm going to ask for any final questions in the chat box. I see a lot of folks sharing emails with me so I can get them these slides. That's really great. If there are any final questions in the chat box, now is your time. Okay, it looks like our panel has answered most of the questions here from this group. So I am going to, where do you send your attendance certificate to? You just keep that attendance certificate for your own files. If anybody has any questions on the line, they can send me an email afterwards. I will make sure I drop my email in the chat box right now if I didn't get to answering any of your questions. I'd like to say thank you so much to Margot, Laura, and Jeanette for presenting today. Obviously a very great program you guys have worked to build. Thanks so much for building the time into your day. And with that being said, we're going to end the presentation here, but if there's any other questions or concerns or want to follow up, feel free to email me through the Southwestern Ontario Stroke Network. It's Morgan Scott, or you can connect with any of our partners who will put you in contact with me. Have a great day, everybody.
Thanks, Morgan.
Thank you.
Thanks, everyone.